So how many of you guys were at the San Francisco or not the Sacramento conference? Okay, so some of you were there, but some of you are new. So this is, you know, an update of what we did at the first conference for Trisomy X in Sacramento. And at that time we had, you know, a smaller number of girls in our study, and I reported on at least what we'd had to date. I think we had 12 or 13 girls at that time, and I think now we have almost 40. I don't remember the numbers exactly. And so we have a lot more girls with triple X that have participated in our study. A big chunk of those girls are girls who were actually diagnosed in the prenatal period, and we followed for 2 or 3 or 4 years in terms of their development. And then some of them were girls who are older, you know, school age, teenagers, young adults, and that we've also seen as well. So, so I'm going to be telling you a lot about what we know from the literature in terms of triple X, what we know from our research in terms of triple X, and then just have some times at the end for discussion and comments and everything else. So this is kind of our outline. We're going to talk about medical problems first in trisomy X. Then we're going to talk about development and neurodevelopmental disorders. We covered a lot of these things, you know, kind of briefly this morning. So we can also go through, you know, briefly again and talk a little bit more specifically if you guys have questions. And then we will talk as I go through about results from our research. So our sources are, you know, those prospective cohort studies that I talked about are really some of the good studies in terms of describing some of the general features of triple X in the strengths and weaknesses. And we also got a lot of information from medical or journal articles that have been published about case studies and case reports and case series. And then I guess now we have more than 50 triple X patients in our study. So I don't remember putting together all these slides. It's been a while. So so the age range that I'm going to describe on is 39 girls who are between the age of 3 months to 28 years. So that's a pretty big range. But the mean age was 6.1 years. So even though the top end is 28, what that's telling me is a lot of the girls that I've been following are really young and are in more that school age group. And so what I don't have the advantage of having is a lot of prospective data. We have, you know, 2, 3, 4 years, but that's when I started, it was in 2004. So I don't yet have, you know, a lot of experience in terms of this is the prenatally diagnosed girl at 4, and this is what she's like when she's 12. So I have, you know, we have what's called cross-sectional data, a single point in time for a lot of girls that are older, and then a couple points for some of the younger kids. But when we look at the diagnosis, when we say, okay, of those 39, why were they tested? Why do we know they have triple X? 23 were prenatal, 14 were diagnosed either between 6 months and 4 years of age because of developmental delays or low muscle tone, and 2 were diagnosed a little bit later because of learning problems at 6.5 and at 10. So, so that makes up, I think, the 39, if I can do math. So we're going to talk a little bit about medical care, because this is something that some parents will say, you know, what am I supposed to do in terms, is there any other medical evaluations, any other specialists I need to see related to the triple X? Is it just the developmental pieces I'm looking for? And so I want to talk about some things that we know are related to triple X in terms of medical features and some of the recommendations I have for those things. So first of all, with the growth. So everyone hears, you know, triple X women or trisomy X women are very tall stature. They're tall when they're younger. They have very long legs. And in general, that's true. Their stature and their height is usually above the 75th percentile. But it's the 75th percentile, and it's not always the 95th percentile. And so, you know, they tend to be in the upper quarter of the class, but not all girls with trisomy X are tall. And I've actually had a couple that we've had to evaluate for short stature that have had other endocrine abnormalities related to short stature. So, yeah, and I never update this because it takes like 7 years. So, but in general, cancel. In general, the height, the final adult height, ranges between 5'6" to 5'9". So that's tall, but it's not overly tall. And they do have longer legs, so longer lower segment length or longer legs than they do relative to their upper segment length. Puberty in some girls was slightly delayed, so from 6 months to a year. Now this isn't always, but but bone age sometimes tends to be a little bit behind. Bone age is kind of your, kind of like your physiologic age where your body thinks you are, and then puberty tends to kind of go along with puberty starts at a bone age that's more, more typical. So these girls can be a little bit behind in their bone age and start puberty a little bit later. The average age of menses in the prospective studies was 13.6, and that's a little bit older than the general population where it's like 12 and a half to 13 in girls. It still usually follows mom's time of her period. So women are very likely to start their periods, or girls are very likely to start their periods right around the same age as when their parents did, and when their moms did. And so, yeah, not when their dads did, hopefully. And so, so sometimes it can be a little later than expected for that. And then a few of the girls actually described in the literature have had precocious puberty. They started puberty even early. And so, it's kind of been all over the place, and I'm not sure there's a definite trend, but the majority of the studies describe a little bit of a delay. So we're going to talk a little bit about puberty and fertility in XXX, because there are some things that have been associated with it that I think are important for parents to know about. One of them is called premature ovarian failure, and that means that the ovaries stop making the hormones and oftentimes the eggs that they're supposed to prior to when they're usually due. So normally, menopause starts in the 50s to early 60s, and in premature ovarian failure, the definition is that you start to lose ovarian function prior to age 40. It's also sometimes called premature menopause. And when there's one study that actually looked at 52 women who had trisomy X and described secondary amenorrhea, or secondary amenorrhea means they started their periods and then they stopped them. So that's premature stopping of their periods. And that happened in 2 of 52, so 3.8 or 4%. So that's not super high. It's not a big risk when you look at this group, but it is still something that's been described kind of over and over in little different research studies about women with XXX who might have premature ovarian failure. The first actual reported case of XXX that was described, the first super female article, was describing a 19-year-old girl who had started her period and then had very early menopause, or at that time it would be called ovarian failure. And so, we know it happens, and it's been reported a lot in the literature in different single cases. But I do think it's probably around, 5%, 3 to 4 to 5% in terms of, looking at all the literature together. And when we say premature in general, it doesn't mean, that one first case report describes a 19-year-old who lost her period and ovarian function. But the cases that are more likely to be described they're a lot older. So it's more like they're, 35, 36, 37, and then they're starting to have menopausal symptoms. So there's been 3 reports that the premature ovarian failure has also been associated with autoimmunity and thyroid problems. So it seems that, and sometimes we think that premature menopause or ovarian failure might be related to an autoimmune condition. And so it was interesting that in 3 of those cases they were actually together. And so that's talking about that. So my recommendations with that are, just being aware that it's a risk. The girls generally don't, so even though this is a risk, when they're young, it's not necessarily something you have to monitor for when they're 13, 14, 15. You want to make sure with all these girls that they're starting puberty when they should, or maybe a little late, but they're being monitored if they don't start puberty, and then that, they're progressing through puberty in a normal way. If there's any concerns about puberty where they're having really irregular periods, or they're not having periods, they stop having their periods, then it's realistic and a good advice to go and seek, further evaluation. The majority of time when this has just been described in the literature, it's more that they're starting to have menopausal symptoms, hot flashes, irregular periods, other things in their late 30s compared to when people usually do in the 40s and 50s. And then talking about fertility is many women with triple X have had very normal fertility and normal children. So actually, of the 11 girls that they followed here in Denver that were diagnosed at birth and then followed all the way into adulthood, 8 of the 11 girls actually got pregnant and had children, and one of them had a baby who died of SIDS, but that was probably unrelated to the triple X. And then there have been various reports of women with other abnormal ovarian abnormalities, so either abnormal ovaries, lack of or decreased number of eggs in the ovaries when they look, and so that's important to know that in some cases there can maybe be an effect on fertility as well. The majority of times it's normal, but sometimes you're at a little bit higher risk of having problems. And then there's also some reports of an increased chance of medical problems or malformation in the children of triple X moms. And that was one paper where they described kidney abnormalities, I think a club foot, and some one other musculoskeletal defect, or no, a heart defect in the daughter of a child with, or the daughter of a young woman with triple X. So, you know, I do think there should be some counseling around if the girls are planning on having children. There should be some counseling prior to conception that describes kind of the risks and make sure that they have good prenatal care so that they can get good follow-up there. One thing that a lot of people ask is, you know, what are the risks of passing along triple X? You know, if she has 3 X's, does that necessarily mean that the kids are always going to have 3 X's? And we talked about this a little bit. But, you know, some people would say, well, it must be a 50% chance, because isn't it a 50% chance that 2 of the X's are going to go into the egg and when you're making eggs? And so what actually happens is that the body kicks out that extra X. So where if we took, you know, a normal girl's ovaries and looked at all the eggs, we would have 0.5 to 1% would have an extra X. And so, or a missing X. So they want 0.5 to 1% would have an aneuploidy of the X, or an abnormal number of X's. And then if you look in triple X, it's like 3 to 4%. So it's a little bit higher, but it's not 50%. And so I think that's just really important for everybody to know. But we have had cases where the mom has had triple X and then the daughter as well. So these are my recommendations. So I definitely recommend an endocrine evaluation if there's late puberty. Actually, I think 1 year before there's late puberty. So if you're not seeing, you know, if mom started her period at 12, it's okay if she's still not starting her period at 12. But I like, you know, as a physician, I like to kind of not wait and see too much. So if you go at 13 and she still hasn't had her period, sometimes people will say, oh, let's wait another year, let's wait another year. So you can never tell exactly what 1 year before late puberty is going to be, but I think with these girls it's always good to seek care as soon as you're starting to have a concern. So, things aren't kind of coming along the way they should. Let's talk to our primary care doctor. Let's see if it's time to start, you know, initiating an evaluation so that you can, you know, she can be treated when she needs to. The definition of late puberty in pediatrics is no breast buds by age 13, or no menses, menstrual periods, by age 15. So those are that's the kind of guidelines that general pediatricians use to determine if it's time to refer them on to the endocrinologist. Also, if they have really abnormal periods, I think it's a good idea to have them evaluated. And we talked about genetic counseling and a good gynecologic exam prior to pregnancy, and close monitoring during the pregnancy for malformations or other problems in the baby. Okay, so motor tone and coordination. So this is another area where a lot of girls are diagnosed with things like hypotonia or poor coordination or motor skills deficits. And I think one thing that's really important to talk about before we even start talking about this is what the medical definition is of low tone. Because when we think about tone, kind of in the layman's world, tone, muscle tone is how tough you are, you know, how cut you are and kind of bulked you are. And that is not the way we use it in medicine. So in medicine, what tone means is the resting resistance in the muscles. So if someone has very high tone, they're very stiff, or there's a lot of resistance when you're moving them. So their arm would be very hard to move if they have high tone. It's very stiff. And that would be something like if you see somebody who's had a stroke or a brain injury and they have, you know, higher tone in their arms and kind of contractures. The low tone then is the opposite. It's being a little bit more floppy and having less resistance in the muscle. So it doesn't matter how much muscle bulk somebody has or even how much strength somebody has. The tone is actually that amount of resistance. And so that's something that is definitely impacted in XXX. In our sample, 72% of the girls had decreased tone, and when you read the literature, it's very common to see comments about low muscle tone. In 1989, Jim Salbenblatt, who's actually a professional here in Colorado, did an actual motor skills study on 11 girls with XXX who were diagnosed prenatally or diagnosed at birth. And what he found was that their gross and fine motor skills were generally less than the 10th percentile. Almost all of them were. Gross motor skills are kind of your big muscle movements, so walking and running and climbing stairs. And then fine motor skills are what you do with your fingers and dexterity and picking up small objects and things like that. He also said that there were they had problems with sensory motor integration dysfunction. So we've talked a lot about kind of sensory symptoms and so that's something that he saw. And then also a delayed age of walking. And in our study, the average age of first steps in the kids who had started walking was 15 months. So in the general population, it's 12 to 13 months. 12.6 is the average age of first steps. So it's definitely more, it's higher than that. But the range of normal is still, in the general population, up to 14 months. So it's kind of 1 month late compared to what we'd consider, time to start to be worried in general pediatrics. The other thing that they have a more difficulty with is what we call visual motor coordination. So that means visual motor coordination is a set of skills where they first have to, we give them a test where we say, okay, copy these pictures. And the pictures get harder and harder and harder as they go on. So the first one's like a circle. The second one's like a cross. The third one's, a couple overlapping circles. The fourth one's this really complex thing with all these shapes. And so what they have to do when they're doing that task is they have to be able to see that, what the shape is. And so that's the visual part. And then they have to be able to use their motor skills to copy it. So it takes a couple steps to be able to do that. And what we found when we did that testing is that their overall scores in that area were low. And 50% of them were definitely delayed. But when we looked at where it was breaking down, is it their ability to see the complex picture, or is it more their ability to actually draw it on the paper and do the motor planning to copy it? The problem was with the motor skills. So if you gave them, 8 choices of the other complex pictures with little lines in different places, they were able to completely match which picture matched which other one. They didn't have to use any motor skills. If they could find the details and match it. But when you asked them to actually draw it, they had a really hard time coordinating to be able to draw it and to get it down on paper. So that's, and that a lot of parents will say they see that, and they also see, laborious handwriting. It takes forever to write out, something, and sometimes it has to be really meticulous, and then they start over, and so I hear a lot about handwriting and motor coordination too. So usually what I recommend is occupational and physical therapy evaluations and treatments for the motor problems, and a lot of the kids I know who have been in this room have gotten OT or PT. And also, when it is time in school, since sometimes those motor skills can be a problem, and especially if handwriting is slow, then to introduce keyboarding and assistive technology to be able to help them be able to type their notes in class and be able to use a computer in class so that they don't have to spend all that time writing things out. The other thing in this that's important is that a lot of times people get, OT until they're 3 or 4 years old, and then they stop. And they say, well, should we keep getting OT after that? Or the OT kind of said we were okay. And sometimes you can still do occupational therapy or physical therapy after that age to work on a lot of different things. So definitely to work on motor skills and motor planning and coordination is still, if they're still having difficulties, they definitely can continue in OT for those types of things. And then also in terms of, self-help and self-regulation, and occupational therapists do a lot of really great things to help with kind of making life functional and easier. And so, you know, if they were kind of kicked out or discontinued from occupational therapy, but you're still seeing problems in that area, then it's definitely worth kind of looking again to see if there's an occupational therapist who might be able to work on some of those skills with them. Okay, so tics and tremors. So I don't know if anyone in here's daughter has tics, motor tics. So motor tics are what we call simple motor tics, are things like eye blinking, you know, or head twitching or little movements with the mouth, and that's a motor tic. And in our research, it was 5 out of 39 girls had motor tics, so it was 12%. Most of these girls had tics right around the time 6, 7, 8, and that's actually the time that most kids get tics, and it's actually up to 10% of typically developing kids, or kids with typical chromosomes, have tics as well. So I'm not sure that it's definitely that much higher than in the general population, because that's a pretty equivalent number. Although in XYY we see a lot of tics, and in XXYY we see some tics, and in XXY we see some tics, and so and those ones are a little bit higher. So you know, so there might be some propensity there for tics. Tics themselves are not dangerous. So if you see them, it doesn't cause any, you know, physical or medical problem. It's usually not the sign of a seizure or something else. But it's important to have an evaluation to know, is this definitely a tic versus, you know, a more subtle sign of a seizure, which can be more common in XXX. So if you see it, I wouldn't, you know, just ignore it and say, oh, that's no big deal, but I would have it evaluated and make sure a neurologist thinks it's a tic. But then if they are having tics, it's not, you know, it's not really a big issue medically, but I think it's a big issue socially, because you know, these girls already struggle in a lot of ways with social skills and social development, and anything that we can do to help them be, you know, stand out less, I think is an important thing to do. So there are medications that you can use to treat tics. Sometimes kids get more tics when they're anxious. So if you see a lot of ticking only in situations where they have a lot of anxiety, I actually usually treat the anxiety and then the tics go down. If they're just having a lot of tics all over the place, then I treat the tics. And those you treat with the dopamine medications that can actually help block the motor. The dopamine is a neurotransmitter in the brain that actually works on the motor system and can lead to tics. The other thing that's important is some of our girls with trisomy X are on stimulant medications, which are the medications for ADHD, and tics can be a side effect of that medication, of those medications. So if they start on medications and they start to have tics, then usually if you keep treating, you can kind of what's called treat through the tic. So if you keep giving it to them, the tic will go away. If it doesn't go away, then it's a reason that I change the medication, because I don't think it's very productive if they, no matter who cares if they can pay attention the whole time if they're having all these kind of funny tics. I think that's going to impact their social development a lot. So then the other thing is tremor. And, you know, I was seeing a lot of tremor in the boys who had XXY and XYY. And so we wanted to see if the girls had tremors as well in their hands. And in our study, we had 6 of the 39 girls who actually had tremor. And I think, and this was 15%. So this isn't a super high number. But remember that a lot of our girls are really young. And so in the boys, we don't usually see tremors start until they're, you know, 8, 9, 10 years old, in late school age kind of ages. And so, you know, this 15%, these 6 girls were some of the older, you know, some of that older group. So I think if we just took out those younger kids, you know, the percentage would be a lot higher in terms of the tremor. And what we usually see is a little just bit of shaking and tension tremor in the hands. So when they're resting, there's no tremor. When they're trying to do something like writing or eating or drinking, you sometimes see just a little shaking tremor. And we don't know what is causing it. You know, I'm doing some collaborations with the person who's a movement disorder specialist, a neurologist, and we're just really interested in better understanding if there's anything we need to do to treat the tremor, if it's coming from, you know, can this tremor give us a clue into some of the genes that might be dysregulated? Because we know a lot about some of the tremor genes. And also if it might be something that might help us increase testing. You know, if we can really make sure neurologists and pediatricians know, if you see a tremor, you got to test them for XXX or XXY because, you know, kids don't usually have tremors. It's rare for kids to present with tremors. And so as a pediatrician, I never saw it until I started working with these kids. So it's something that, you know, is that some other clue pediatricians can use to help us, you know, increase the diagnosis rates a little bit. But so if you see it and it's impacting them, you can treat it with the medication also. Or, you know, but usually it's not so severe, so it's just kind of there. And, you know, and some of the other medications also can make it worse. So if they're on Depakote or if they're on stimulants, the ADHD medication, sometimes that can make it worse. So you just want to balance and make sure, you know, is the benefit of the medication they're taking, you know, outweighing the what's happening with the tremor, and then give them some supports in school. The keyboarding can be a very good support. It doesn't take as much as you think to actually do the typing. The tremor doesn't interfere with that as much as it interferes with handwriting. There shouldn't be tremor at rest. So when they're just sitting there, if there's ever tremor when they're just resting, then it's something oftentimes more significant, and so you want to get it evaluated more. I still think if you see a tremor, you should see a neurologist, but it's usually, you know, they might not know, and you can say, well, you know, this happens in girls with XXX. So, and then there's seizures, and I guess I'd like to just see the hands of people in this room who have girls who have seizures. Okay. We've got one table in the front. You guys are the winners. So, you know, it's probably pretty similar to what, you know, we have 10 tables here, and we have 10%, or one of the tables has seizures. So, you know, in 2004, there was a paper that described 7 girls with trisomy X that were evaluated using an EEG, and 4 had complex partial seizures. And then the ones who had the seizures, they tended to have a lower IQ of those 7 girls. In our sample, we've had, you know, 39 girls, and 4 of them have had seizures. So 10% of our group has had seizures. When we look at the MRI, there's not any abnormalities of their brain that we can say why they're having seizures. They're normal MRIs. And they've usually responded very well to just standard seizure medications. Sometimes they've had to switch from one to the other, but in general they're not on, you know, 3 medications to try and control the seizures. And they usually started not in the early period, but more between 5 to 10 years of age. So that's important for a lot of you in here who I know have little ones, to know that this is still something that they're at risk for. And so it's important to know about. And then they also do not always have, you know, full generalized tonic-clonic seizures, but more, you know, partial seizures where they can have more mild symptoms. And one of these girls even had what we call absent seizures, which are the very, also, you know, classically called petit mal seizures, where it was really just more of a staring spell with a few little lip movements that was associated with it. So if you see things like staring spells or funny movements or anything else like that, it's worthwhile going to see a neurologist to get the appropriate evaluation, because the medications then can help stop the seizures. You know, even though we haven't seen any abnormalities in the other girls with XXX who have had seizures on the MRI, you know, if they have a seizure, I think it's important for them to also have an MRI as well. And then, you know, it's always important to evaluate for other causes of seizures. So anytime you see a medical problem that, oh, well, that's related to XXX, don't just always do that. You know, always say, well, let's make sure it's nothing else first. So, you know, sometimes infections can cause seizures, other metabolic abnormalities can cause seizures. There's a lot of other things that can cause seizures. So make sure you always ask those questions. Oh, we know it's related to XXX. Are we sure it is in this case? Because that's a trap that sometimes, you know, you can fall into if it might be related to something else. And then seizure medications, like I said, can be very helpful. And sometimes, you know, we've had a couple girls where the seizure medications are also often mood stabilizers. So if the girls are a little bit, you know, having a little bit of a problem in terms of mood regulation, the seizure medications can even out that mood. And some of the seizure meds we use as mood stabilizers, even if they don't have seizures. So Depakote is the name of one medication that's used to treat seizures, but oftentimes it's just used to treat mood instability and tantrums also. Okay, so now we're going to talk about the kidneys. So does anyone in here, do any other kids have kidney problems or kidney abnormalities? Okay. Usually those ones you do know about. So in Denver, there was 1 in 11, this was the Denver study where they followed them from birth. 1 of the 11 had a very small atrophic kidney. That means a kidney that didn't really grow, it stayed small. And then in the literature, there's at least 6 to 7 other various kidney malformations that are described related to XXX. In our sample at the Mind Institute and here, we've had 6 girls who've had kidney abnormalities, so 15%. And those have been what we call multicystic dysplastic kidney, or just one kidney on one side, or reflux. So we've had some renal problems, and it seems to show up in the literature and also in our sample here. So we usually recommend a kidney ultrasound when they're diagnosed, just to make sure that there are no abnormalities. If they do have reflux, it can make them more likely to have infections and other problems related to renal failure. And if they just have one kidney, sometimes it's good to know. A lot of people are walking around with just one kidney and don't even know it. But it's good to know because you're a lot more aggressive about making sure they don't have urinary tract infections or they're treated aggressively. And then also sometimes some medications that might cause some kidney damage, you'd be a lot more careful in terms of using those types of things if you know you only have one. So, and then the heart in XXX, this is something that when I first started working with these girls, hadn't seen any reports really or had any problems in girls who'd had heart defects. And I guess that would be another thing I'd want to ask in this room, if there's anyone who's had heart problems in the girls with XXX in here. Okay. Oh, yeah?
Well, it resolved itself. Was there a birth?
Yeah, yeah. So, and that's usually what I've seen too. Well, I saw one girl who had what's called a ventricular septal defect. So that's a little hole between the 2 bottom chambers of the heart. And after they identified it when she was born because she had a murmur, but then they just followed it and it closed on its own. So, you know, there's no surgical interventions that are needed for that. But it is important to know about it because if it doesn't close on its own, it can cause a lot of differences in the pressures in the heart and can, you know, lead to heart failure if it's a severe case. But there was an abstract at the last genetics meeting where they presented, and I couldn't find the actual abstract, but they presented, you know, a list of 5 or 6 girls with XXX who had different heart abnormalities and recommended an echocardiogram. So my feeling, I guess, is, you know, if they're 12 or 13 or, you know, whatever age they are, and they haven't had any problems, they're unlikely to have a heart problem. But if it's a brand new baby, maybe while we're doing the ultrasound of the kidneys, we just make sure the heart is okay too, and then it leaves all our minds clear. And I think we'll know more about these risks as we have more and more patients. These are some of the other numbers in terms of the patients that we saw that had other medical problems. So strabismus or lazy eye was one that was there in 15%. Significant dental problems in terms of crowding and needing orthodontia and lots of dental work was there in 31%. Allergies like food and environmental allergies in 21%. Asthma in 23%. Hospitalizations for pneumonia in 33%. So those are high kind of respiratory problems, and they're higher than we see in general pediatrics. You know, 33% of kids are not hospitalized at some point in their infancy or young childhood for pneumonia. So it's not uncommon for little kids to get hospitalized, but it's just this is higher than you would normally see. And even when we kind of account for family history of asthma and allergies, it seems like it's higher. And we see the same trend in XYY and in XXYY and XXY. So, you know, I think there might be, I don't know what it is yet, but something involved in immune function or, you know, something when they're young and that they're getting more respiratory infections or their clearance or ability to clear infections. So we're going to have to do a little more work in this area, but we have National Jewish Hospital here, which is a great respiratory hospital that does a lot of work on genetics in asthma and respiratory conditions. So eventually we're going to get hooked up with them over there to do some more work in this area. And then abdominal pains. I don't know how many of the girls in here have had complaints of kind of, yeah. So that one comes up, so that's more than 26% if you look at the people in here. And you know, we know constipation is higher, and constipation occurs in a lot of girls, but it doesn't always seem like their abdominal pains related to the constipation. I don't know if you got your experiences with that, but when I ask families that, well, is it only when they have constipation? And it doesn't seem like it. And you know, we know they have a little bit more anxiety, so maybe it's a, you know, somatic complaint related to anxiety, but it's always their stomach. Like kids have other things, they complain of headaches or, you know, so I don't know what that is yet, but I think, it's something you guys all talk about a lot, and so we're going to keep investigating and see if we can find a pattern or trend or something, to be able to understand that a little more. This is a little bit about Tetrasomy and Pentasomy X, and I think we had a family or two that actually have mosaicism with extra X's. And so I wanted to make sure we don't ignore you. And so these are 3 girls. All these 3 girls are unrelated and have Tetrasomy X. And I think it's so amazing to see them because they all look like they could be sisters. And so, they all kind of have the same haircut and the same hair color, which I think makes it look a lot the same. But they have, you can see a little bit more wide-set eyes. They all had these freckles over their noses that look the same, and so very similar facial features. So some of the features we see in Tetrasomy and Pentasomy, but you also see these to a lot of the same degree in Trisomy X. So hypertelorism are the more wide-set eyes. Epicanthal folds are the folds that are typical in people of Asian culture, but usually in Caucasians there's not epicanthal folds on the inside of the eyes. The broad nasal bridge on the top, that's up at the top. Narrow shoulders, so having kind of narrower or rounded shoulders and having low muscle tone. And you can see that in the little girl at the bottom. A lot of times they have that kind of protuberant belly because they don't have great tone in their strength, and they have low strength, or they don't have great tone in their belly, and they have low strength in their back and their core, so they kind of, sit like this a little bit. Some of the other medical problems that we've seen was something called craniosynostosis, and that's a big word that means that the skull bones fused a little bit early. So it can lead to, oftentimes needs surgery, but it can lead to kind of a misshapen skull. Cleft lip and palate we've seen. These are in Tetrasomy and Pentasomy. So this is, again, not as common in the trisomies. Hip dysplasia and club foot, kidney problems as well, GI problems, and heart defects. So, a lot of these things, as you add more X's and Y's, like we talked about before, so in the girls, as you add more X's, you're going to get more and more developmental problems and more medical problems. This is a girl who had Pentasomy X, and she had a lot of anxiety. And so here you can see she would get very, very nervous, and she would pick her skin and scratch it. And she did really well once we started her on treatment. We just started her on a little bit of Zoloft, and she did great and stopped picking. The other thing that was interesting about her is I saw her when she was 17, and she had never had any pubertal changes at all. And the doctors had said, oh, well, don't worry. She's got very low cognitive scores, and she's not going to go, she's not going to reproduce anyway because of her cognitive ability. So you don't need to worry about her estrogen or her progesterone or her going through puberty. And that's wrong. We need our estrogen for bone density, and we need it for our health, and so if they're not going through puberty, no matter what their cognitive abilities are, they need to be treated medically with the types of treatments that they need. So so we got her kind of hooked in there, but it was sad to see it gone on that long, and the parents had asked and gotten very poor advice. But she had, and they also have a very similar pattern. So the speech delays, and you guys have all seen this, the receptive language or the understanding of language seems much better than their ability to express. And their scores are always discrepant, and it's described as oftentimes a mild dyspraxia or apraxia, and that we can see very commonly. And as you add more and more X's and Y's, you oftentimes see that become more and more significant. And so with her, she had very poor expressive language, but she really had much better receptive language even as a young woman. Okay, so now we're going to talk a little bit about the development and neurodevelopmental disorders. And a lot of these, this is the list that we talked about, a lot of these this morning in terms of, this long list of all these things that could go wrong and how do we, fit it together and how do we understand it. So speech and motor delays, learning disabilities in terms of language and reading. And in Trisomy X, actually, we talk a lot about how reading can be impacted. But in Trisomy X, we oftentimes have more of a global learning disability where math can also be impacted and have problems. So it's not as clear as in the males, where it's, usually more really reading and language. In the girls, it seems to be kind of more everything. And people ask me why I think that, or why I think that happens. And it's because on the X chromosome, there's a lot more genes than on the Y chromosome. So if you have, so there's a lot more things, a lot more genes that are expressed. So the more X's you have, the more genes you have that are being expressed in an abnormal way, and then I think you're more likely to have more atypical development. So compared to even an XXY male, they only have 2 copies of those X's, and one of them's kind of turned off. And so in a triple X girl, you have 3 copies, and 2 of them are kind of turned off, but you still have, 3 active copies of a lot more genes compared to, let's say, XYY. So there's more genes on the X, so the more X's you have, the more difficulties you have kind of globally. Sometimes we hear about intellectual disability, which is the new term for mental retardation, and it's definitely not the norm in trisomy X, but because the curve of cognitive abilities is shifted down, you are more likely to find people who do fall in that range than, in XX females. When they do have mental retardation or intellectual disability, I think it's really important. A lot of parents are very resistant to, oh, I don't want that label. That's not a good label. But in general, if it's there, it can be a very helpful label in terms of lots of services that are available and community supports, and especially as they get older into adulthood. And so I always make sure that parents know that, it's not what you want to hear about your daughter, but it can definitely be helpful and is important to establish if that's the level of cognitive functioning. And some people have never had, they might be 12 or 13, and they've only ever been tested through the school system. And the schools, some schools will tell you about, oh, their IQ is in the mental retardation range, but a lot of times the schools aren't qualified or supposed to give diagnoses about cognitive ability. So they're not supposed to give a diagnosis of ADHD because they're the school. They're not qualified to make that assessment. Or they're not supposed to give a diagnosis of mental retardation. And so, so kids can get kind of plugged along through the school system and never have an evaluation where someone gives them that diagnosis or other diagnoses like ADHD or other things. They're just kind of treated and accommodated for it through the school system. And so I think it's important to have those outside evaluations to be able to document where they are in terms of their cognitive strengths and weaknesses, and that can help with a lot of planning for school services and adult services, and especially if they do fall in that mental retardation range, it's important. The other thing that I think it's important for is sometimes the schools kind of stop testing it because they're in the special ed system, and but they might still be getting speech therapy, or people will say, well, their speech therapy isn't working. Well, so, the girls can have a lot of language impairments, but it's really also important to know where their cognitive abilities are. So, for example, if you have a girl who's 12 and, they say, well, her speech and language age equivalents are at the age of 8, and she's not seeming to make any progress. What should we do about her speech therapy? Should we increase it? Well, for me, it's really, you need to know more than just what her speech and language age equivalents are. What if we test her and her cognitive abilities are at 8? So the way she thinks about things and other things are also an 8-year-old. Well, you can give her more speech therapy, but she's probably, her speech and language differences compared to peers is more related to her cognitive abilities. Compared to, oh, you test her and her, her cognitive abilities are 10 or 12, but she's still 8 down here. Well, then, yeah, there might be speech and language strategies that can help you. So, so I think it's always important to kind of think about them, from where they are developmentally as well in terms of what kind of therapies and treatments are going to be helpful. So then, short attention span, we've talked about attention difficulties. Hyperactivity can definitely be present in triple X. We talk about how they're more likely to be kind of the shy and withdrawn ones, but not always. You sometimes have those little monster girls that are running around too. And then social skills difficulties. Oftentimes I think that is related to language and some of that executive function and poor judgment and a little bit of anxiety, but there's a lot of pieces that can go into that. Sensory integration problems are more sensitive to their environments. They can be a little bit more agitated, a little more cautious because of it. And then we do see more problems with anxiety, depression, and mood disorders. So here's our favorite picture, right, of all these big circles, and this is how, so not everyone with triple X has all these difficulties, but sometimes, you do see certain components of it, certain constellations of, ADHD and anxiety, or learning problems and speech problems that are really poor, or social difficulties that are really bad. So, so I think, this kind of puts everything together in a way that I don't like to think about it this way. But this is, I think, how it's oftentimes, it's hard to interpret what all those behaviors always are. So this is our comparison of the kids. So a lot of people ask me questions about, well, do the prenatal girls have a prognosis that's different than the postnatal girls? And so this is a comparison of prenatal versus postnatal in terms of all these different problems. And so, in our prenatal group, 90% had a normal IQ, 20 of 22, but 8 of those, even though they were in the normal range, 8 of those were kind of in the borderline range. So they were low average or low of the ones who were normal. And then we had 71% in the postnatal group that actually had what we call a normal IQ, but half of those were more in the borderline range. So what we see more commonly with the full-scale IQs are that it's about 85 in the postnatal and about 90 in the prenatal group. The average IQ in the general population is 100, and so, so 85 is kind of one standard deviation below. But there's still a big spectrum around that. 68 to 76% needed special ed support, and then it shows you the differences in the numbers that actually had more significant speech delays and motor delays. And then in terms of PDD or autism spectrum diagnoses, there were no one, there was one girl, I wonder why she's not in here. There's one girl who'd been diagnosed with PDD, and I didn't remember if she was prenatally or postnatally diagnosed. But it's not a big problem, and I don't know, has any of the girls in here ever been diagnosed with autism or concerns of autism? So, okay, so one. But ADHD is not uncommon, so 30% and then 50%. And I don't know if that, in this room, if there's other people who've been diagnosed with ADHD, or if I've said, sometimes I'll tell you. Okay, and then, so these are things, this was the ASD screening, so we talked about this morning. These were the behavioral profiles that we see on the BASC. So this is kind of what the parents reported about what the behavioral strengths and weaknesses were. And the biggest concerns in XXX were anxiety and then inattention. And, one thing that was also a little concerning to me is that aggression scores were so low. So it's like the girls weren't aggressive, but they were almost under-aggressive. Like they weren't sticking up for themselves like they should be, and they weren't being assertive when they needed to be. So it's, it's not a problem behavior, but it might be a problem if they're too low. And then adaptability and social skills were also right on that borderline where, some of the girls had more significant problems than others. We talked a lot about ADHD. In our study, 53% met criteria for ADHD, and most of them were that inattentive subtype. So the kids weren't the girls that were all over the room. They were very quietly inattentive and, needed to be redirected, but they weren't bugging their neighbors, and so they didn't always call attention. The teachers weren't always calling the parents saying, oh my gosh, you have to take care of this, because the girls weren't being bad, A lot of these girls are perfect at school and then get home and completely melt down. How many people have that? Yeah, they're so good at school, and I almost think that speaks a little bit, it speaks to their need for structure, but I think it speaks a little bit to anxiety, like to wanting to make sure everything stays okay, because when they get home, they're done. That's it, they got to let it out. So I think it's important to treat the ADD or the ADHD, and it can really make a big difference in terms of concentration and focus as well. And then we talked about these before, and what all the things to make sure it's not when you start the treatment. So, good evaluation, considering all the different parts of XXX is important in terms of the ADHD part also. And then these are the medications. These were all slides from the other one, in case people had questions that they wanted to kind of reference back to. This was 65% of our girls with XXX responded to medications for ADHD, so that was an important finding. It's not 100%, and I've used a lot more Strattera in girls with XXX with actually good results, because it helps a little bit with that anxiety and a little bit with attention span also. And then anxiety, I think, is a big issue that a lot of the girls do struggle with. And we see it in different ways in these girls, but sometimes with a lot of perseveration or talking about the same thing, nail biting, thumb sucking, chewing on their shirts, showing things that way. irritability and tantrums and meltdowns. And then sometimes, avoidance behaviors. If they're not wanting to do their work, it's not always because it's too hard. Maybe they're just, sometimes they get anxious about, being wrong or things that are a little more challenging. And then the extreme shyness. So, a lot of preschoolers who, normally in preschool it takes maybe sometimes, someone 5 to 10 minutes to kind of warm up and join the group. But these girls are, kind of by the teacher's side for the first hour before they go and join the group. And, as long as they get in there, that is good. But if they're always so inhibited, I think it's important to treat them. And then so for therapies, for the treatments, there's 3 different really things I think are important. One is OT, if there's a sensory basis for the anxieties, to get some OT involved with that to help with self-regulation. And then also a counselor and psychologist can work with play therapies and other things, even from an early age, to help with self-esteem and kind of assertiveness and less anxiety. And then the medications are a piece of the treatment too when they're needed if it's severe. And we have good responses also. Almost 70% respond really well to SSRI medications, which is, we think of Prozac and Zoloft as the adult antidepressants, but they can be really good in kids for anxiety. And then this is just, I just want to tell you a little bit about, there's 2 things that are important, and then we'll go to questions. So, what we're trying to understand is kind of what explains the spectrum of involvement. Some girls with XXX have a lot more problems than others, and what we're doing is we're really studying, they all have 3 X chromosomes, so can we identify the genes on the X chromosomes that are related to the different degrees of anxiety, to the different degrees of learning, to the different degrees of, physical stature and other things like that even. So, so we're looking to see, and so you can see there the picture is, in a typical XX girl, one of the X chromosomes is almost always turned off. So that's the black part. Those genes are turned off, and the other one is active, the pink part. But there's some genes that don't get turned off. Those genes, what we call escape X inactivation, or they're not inactivated. And so, so those genes are expressed from both. You get, the protein is expressed from both of those chromosomes. And then when you look at XXX, then you have 2 of those X's that have that area that's not X inactivated. So now you have expression from all 3 areas, and that leads to higher levels of expression in protein. And that's what we're studying, those genes in those regions, to see if we can identify which genes might be related to some of the features of XXX. And then we're also, I don't know how many of you know Lenny. I think she's on the listserv with you guys, and she's fantastic and a great resource for KS&A. And so we're working on a review paper that really summarizes XXX, and we're hoping it's going to be published by December. And it's going to be one of those papers that's available on the internet free of charge on PubMed. And so it's going to have all details about all the important pieces of XXX. And it's going to be have recommendations for treatment, so you can share it with your therapists and your doctors and other things, because it's definitely something lacking right now in terms of literature for families and for physicians to learn more about the syndrome.
Is she not here? Is Lenny here?
Lenny's not here.
Yeah, she was going to be, but I haven't seen her. Oh, okay.
What? Okay. Are tremors haphazard or random, or do they become regular once one is experienced? They don't, they usually start to be a little bit random, like you don't see it at all times. And in general, it doesn't progress a lot. So, it might get a little bit worse over the years. And so, and the kids don't always have a lot of tremors. So, some days you can see it more than other days. But you shouldn't see, so it's okay if it waxes and wanes a little bit, that would be normal. If it waxes and wanes like, you're seeing huge tremors one day and then not the other day, that's more concerning. That doesn't sound like a XXX tremor, and then I would get more evaluation. Appropriate age for successful keyboarding. Fine motor skills are typically adequate. So I start keyboarding early, even when they can just kind of finger do the couple letters. So, kindergarten, 1st grade is perfectly acceptable to start to teach them. They're not going to be typing like normal, but at least they're learning where the letters are and other things. And then some kids in 1st, 2nd, 3rd grade are using keyboarding in school, because even if they're hunting and pecking, it's faster than all that handwriting, which can be hard for some of these kids. If a renal problem such as an incomplete voiding exists, will it be progressive? So incomplete voiding means when you empty your bladder, it doesn't go out all the way. And I don't know that to be associated with XXX. I definitely see a urologist. In some kids, just in knowing general pediatrics, it can be progressive. Oftentimes it actually gets better with age. But it's something that you definitely need a urologist to follow you for. Regarding tremors, do you treat them when a diagnosis is yet to be determined, diagnosis of the cause? Well, I think if there is a kid who has a tremor, then I would make sure they see a neurologist. The neurologist should rule out any other causes besides XXX. And then if they're mild tremors, you don't have to treat them. You can just watch them and just make sure they're not impeding, daily functioning. If they're more severe tremors, then you can treat them with medications. There's medications, propranolol and other tremor medication that you can use if it's really impacting them in terms of eating or writing, or they're really self-conscious about them. Regarding precocious puberty, is this directly related to the XXX diagnosis, or is there also underlying causes? There can be other underlying causes of precocious puberty. So again, it's one of those things where you say, well, it can be associated, but I wouldn't necessarily chalk it up to always being related to XXX. So the endocrinologist should do a full workup for any other underlying cause, and then if that's negative, say, okay, this is XXX, because it's not common in XXX. What age should they be tested? IQ, cognitive problems, and how? Who do we see? So, it depends on where you are. So this varies a lot from state to state. Some school districts in certain states do a really good job of doing IQ testing and of, making sure that you know the IQ, and sometimes that can be enough if they do a good job of that. But other school districts in other states, they're not doing it as much anymore as they used to. Karen Riley's going to talk a lot tomorrow about RTI, which is kind of the new special ed trend of, well, not trend, it's now the law, of response to intervention and how that's going to work in the school districts. I think it's important for them to have a good neuropsych eval when you change from that kind of developmental testing to cognitive testing. So until they're 3 or 4, a lot of times we're doing developmental testing. This is their age equivalent. This is where they are. When they're 5, 6, 7, it's good to get another test around that. And I usually say definitely before first grade. So some of the girls stay back for a year or a little older when they start first grade, but I think, around first grade or right before is a good time to do, another set of now what's more cognitive or psychological testing. And then again after that, first grade, then again in like 4th or 5th grade, and then kind of like before every transition to the next school, so that you can kind of know what's going on and how the trend is progressing. You see a psychologist, usually a child psychologist. If you live in a city where there's a big university children's hospital, that's where I'd recommend going. Or at least asking your pediatrician, who can we see locally, who knows about learning disabilities. The bigger children's hospitals usually have more experience with kids with various genetic and other abnormalities, so they're more likely to do an assessment that kind of takes into consideration those things, and also usually better at testing kids who have developmental delays or differences. So they know how to, they're better at accommodating kids who have anxiety or, behavior issues. Do XXX girls show more fatigue and tiredness? Yes, 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 yes. I don't know why that either. We used to say it's related to the low muscle tone. If you have low muscle tone, you have to work a little bit harder for kind of everything you do all day, and so that gets you more tired. But that doesn't, I see a lot of kids in my regular practice that don't have sex chromosome abnormalities, that have very low tone and don't have that same degree of complaint of being fatigued. So it's something, I've heard that it's there in the XXY boys in the same way, and we need to study it more to make sure it's not a metabolic problem or some other really underlying kind of piece that we can treat. But for, what we've seen is that some of these girls really seem to kind of go up and down in terms of blood sugars. So lots of good protein little snacks throughout the day is usually recommended to see if at least keeping their blood sugar more stable might help them have less fatigue. It won't work in everybody, though. I don't know what that is. Is there a study on girls with bipolar disorder and XXX? I don't know that there's another study. There's been a lot of papers that have reported much more significant psychiatric problems in girls with XXX. And so it's possible, and it's definitely possible, and it's not something that we want to talk about, or we want to definitely oh, we got to be really worried about this. But you know, there are more significant psychiatric problems that have definitely been present in some of the girls and the young women. And I think it's important to, you know, address it early when you start to see symptoms, and then continue to make sure that, you know, they're getting the type of psychiatric care and other follow-up that they need. Because there's a lot of papers about, you know, different schizotypal or schizophrenia and other types of, you know, more significant mental health problems in girls with XXX. And we don't know yet what the course to that looks like. You know, we've been following some of these girls just for a short amount of time. Are those isolated incidences where there's a family history and other, you know, really poor psychosocial types of environments that have led to that? Or is it something that's related to the XXX itself and is unrelated to other pieces? So those are all things that are going to be really important, and then to be able to learn. But, you know, sometimes when there are more significant problems, you know, we need to just make sure there's good treatments and lots of continued support. So that's it. Okay.